Morning, everybody. We'll start on Swiss time, since that's where I'm from. Please, the people at the back still getting breakfast, don't panic. I'm very happy for you to carry on doing that. I guess coming from the WHO, I better get used to getting ignored in the US. That'll be good practice for me. 15 seconds in and I've already triggered a diplomatic incident, so it's going to be a fun session today. So first, welcome and really sincerely thanks for joining us today for this special anniversary symposium. It's great to see so many of you here. In case you hadn't realized, from all the 50s around, that isn't my birthday, unfortunately, but it's 50 years since the World Health Assembly established TDR as a special program for research and training in tropical diseases. Since then, I think you'd agree we've firmly established ourselves as a leader in supporting research that addresses infectious diseases and poverty, and in building the capacity of people, communities, and institutions in low and middle-income countries. I'm also really pleased we're joining up with our friends at MMV on its 25th birthday for this symposium. And amongst the many highlights of TDR's history was the incubation of MMV at TDR 25 years ago. In fact, some of the seminal advances in malaria research have been championed and supported by TDR over its last 5 years. I think we forget now that the original research that established the effectiveness of insecticide-treated nets was TDR supported, as were the trials that proved the effectiveness of artemisinin combination therapy. We've also played a key role in the establishment of the Multilateral Initiative on Malaria, which was designed to strengthen malaria research capacity in Africa. And many grantees supported through MIM are now research leaders, directors, and heads of major research institutes, really contributing to the global effort on malaria elimination. And many TDR-supported scientists, and I know that some of you are in the audience because while I've been having breakfast, I've had the pleasure of speaking to a number of people, regularly presenting their research findings at ASTMH each year, and we're really happy to see that. While we're celebrating many achievements, there's still a lot to be done to eliminate malaria and other diseases of poverty. To that end, we just recently launched our new strategy at TDR. This focuses on 4 major health challenges affecting these diseases, and we're really trying to push the One Health approach into this through epidemics and outbreaks, still our core of control and elimination of diseases of poverty, the impact of climate on health, and also the resistance not just to antibiotics, but antiparasitics and anti-insecticides. So this strategy was developed in collaboration with many of our partners and our supporters, and we're really grateful for those of you who continue to support us and put in to get this strategy together. For this symposium, we've got a fantastic lineup of speakers, and I've got to really be disciplined to make sure we keep to time, because each one of them could have taken the whole symposium, I can tell you, for this. But they've all been strictly warned that they're not going to take the whole symposium, and they will have to be shuffled off in their 5 minutes. But so do forgive me when I'm introducing them. I'll keep it very basic and keep moving for the discussion, because I think we want to get to the end and hear from you as well and give you access to our speakers. So now I'd like to introduce George Jagoe, Executive Vice President of Access and Product Market at MMV, who will also make some comments. George, would you like to come up on stage?
Good morning, and thank you for joining us. It's great to see this remarkable turnout of people at such an ungodly hour, but that's what ASTMH is all about, making a sacrifice for public health. Listen, my comments will be very brief, because really the stars of this event, the ones who are going to energize you, are this active and large panel of people. Simply wanted to say that MMV is really thrilled to be able to have collaborated with TDR and bringing together this group of speakers. And there's one theme going across this mix of very different background of people on the stage. That really is, we've all matured in understanding that the complementarity of the approaches that we are taking in focusing on malaria is probably at its peak and needs to be at its peak in the times we're in. The technologies that have been coming through fast and furious in the last 15 years, let's say 25 years since MMV was created, is remarkable. It's not just in medicines, but across vector control, new technologies, vaccinations, and next generation things like monoclonal antibodies. The world has never had it so good. By the same token, understanding the way this jigsaw puzzle is going to play out is really critical, particularly at a time when the resources that are going to allow countries to put these new technologies to optimal effect, unfortunately, are not as flush as we'd like them to be. So this is really a celebration of the tremendous progress we've made in pushing the boundaries across a number of dimensions in fighting malaria, but B, it's also a call to tighten the degrees of collaboration, rational complementarity of these new tools. So at the end of this, we'll see if we have all the pieces on the puzzle for you guys to think through what the next steps would look like. But I'm going to stop there and invite our first speaker to the stage. The movie. Yes, great. So can someone hit roll film for Daniel, please?
Dear participants, it's a privilege to speak at this symposium celebrating the significant milestones of TDR's 50th and MNV's 25th anniversaries. 2024 was an historic year as ministers of health from the highest burden countries made a commitment to accelerating malaria control in Africa. By signing the Yaoundé Declaration, they pledged to implement an appropriate mix of interventions in malaria-endemic districts and communities, specifically acknowledging the importance of interventions such as malaria case treatment, integrated vector control management, preventive chemotherapies, and malaria vaccines. The benefits from these interventions need to be extended to all those in need. In this year's WHO 2024 World Malaria Report, we highlight the importance of addressing the disparities in access to malaria prevention and treatment. As WHO, we recognize that the most inclusive, equitable benefits from these and other health interventions will be realized by mainstreaming of malaria services into primary health care. As malaria challenges evolve, including the threats of drug and insecticide resistance, GMP is dedicated to supporting development, the deployment, and the scale-up of innovative tools and solutions. Our collaboration with research institutions and industry partners enables us to stay at the forefront of malaria control, helping countries to adapt on emerging threats and maintain progress toward elimination. Equity should also be a guiding principle of innovation and product discovery. When considering the design of the product, careful consideration should be extended to whether it can be accessible, affordable, and acceptable for all in need in the context where it is to be delivered. I would like to conclude by highlighting that the use of malaria tools is leading to success. Cape Verde and Egypt both achieved in 2024 malaria-free status through the dedication of their governments and performing health systems that delivered effective malaria interventions. These accomplishments demonstrate that sustained effort and strategic action can lead to malaria elimination. They provide hope and a model for other countries as we move closer to a malaria-free future. I thank you.
Thanks for those words from Daniel. And I probably should have, when I stood up here at first, explained that I was standing in for Daniel. So those of you who are a little bit shocked to see me behind here, and I am, of course, John Reeder, Director of TDR. Daniel was called away and couldn't make it to the US for the meeting, but kindly recorded a few words for us. So our first speaker, and it really does give me great pleasure to introduce Professor Margaret Gyapong. Margaret is the Director of the Institute of Health Research at the University of Health and Allied Sciences in Ghana. She also happens to be the chair of our Scientific and Technical Advisory Committee at TDR and works very closely with us. So Margaret, please take the stage.
Thank you very much. And who? What an attendance. Thank you very much. Happy birthday, TDR. Happy birthday, MMV. And if you celebrated 50 or 25 years this year, happy birthday to you. In the 5 minutes that I have to speak, I'll be drawing on my own experiences and a document I saw recently published by the Global Fund on how to strengthen gender approaches within the malaria response. And I'm talking about gender-sensitive approaches to malaria interventions. It's no news that sex and gender impact health and well-being by exerting a combined influence on people's environmental and occupational risks, risk-taking behavior, access to and use of healthcare services, and abilities to make decisions about their own health. Any gender transformative program will seek to advance gender equality by addressing the underlying causes of gender inequality in health, including social norms and power imbalances between men, women, girls, boys, and gender-diverse communities. Antenatal care contacts remain an important platform for delivering intermittent preventive treatment for pregnant women and can be an entry point for gender transformative malaria interventions, but we know that there are several barriers to seeking ANC, such as the long distances that women have to travel, the costs involved, and the work and family responsibilities. Such inequities, among other factors, have contributed to low IPT coverage in sub-Saharan Africa. And in 2021, only about a third of pregnant women received the 3-dose IPTP regimen. Hopefully, it would have increased a little more. Malaria programs are already working closely with reproductive, maternal, neonatal, and adolescent health programs. But where inequities in ANC services and reach exist, being intentional about specific transformative activities that focus on peer support and community engagement, amongst others, can address harmful gender norms and behavior that result in poor malaria-related health outcomes and significantly improve ANC access and uptake. The updated WHO recommendations on IPT recommend community-based delivery of IPT, or CIPTP, an innovative approach aimed at increasing coverage of IPT with SP. While not detracting from ANC, it complements ANC, giving all eligible pregnant women the opportunity to receive this treatment in the communities close to where they live, as well as at antenatal care facilities. In Ghana, many years ago, a colleague of mine, when we were working at the district level, decided to include volunteers in the distribution of SP because the coverage was that low. We involved male and female community distributors, and the achievements were tremendous. So I was really happy to note that the new documentation and guidelines is focusing on community IPT. Interventions that engage men and address harmful gender norms in ANC increase couple communication around family planning and ANC. It shifts power relations within couples and supports gender independence for women in decision-making. We've introduced what we call the pregnancy school in Ghana, and it's exciting to see men go with their women, their wives and their partners to antenatal care and engaging in all the activities that go with reproductive and child health, and encouraging the woman to access her treatment. I think that in order not to pay lip service to gender-sensitive approaches to improving uptake of IPT and other interventions, all the social and other networks of pregnant women and girls need to be involved. Their partners, traditional healers, church leaders, and the significant others, and our healthcare workers. We assume they know what to do, and sometimes we leave them out of the matrix. If people are sensitized and uptake increases, stock-outs should be a problem of the past to ensure that expectations are met. Expanding collection of disaggregated data on the grounds of sex and gender, as well as income, geographical locations, race, ethnicity, migration status, and other factors that are relevant and in local context is essential for increasing understanding of gender and intersecting barriers to malaria prevention and control. But those who manage and use the data need to be sensitized on the importance of looking at the issues from a gender lens in order to be able to use the indicators appropriately. At the end of the day, ladies and gentlemen, contextually sensitive behavior change communication that does not exclude the health workforce and a paradigm shift in the way programs are implemented is critical to ensuring a gender-sensitive approach to malaria interventions, particularly for IPTP. Thank you. Less than 5 minutes.
Thanks, Margaret, for a terrific start to the proceedings. So next I'd like to call on Dr. Fatimata Bintou Sall, and she's a research assistant at the University of Thies, Senegal. Fatimata, please, the stage is yours. Do you want to use the mic?
Thank you for allowing me to be here. Good morning. It's not easy to talk after Margaret, but I'm gonna share with you my dream. As a young malaria researcher, I dream not needing to do this work anymore by 2040. You may wonder how this could be possible, because by then, I envision a world where each year, millions of children no longer be threatened by malaria. And that is the vision behind a project I'm proud to be part of and excited to tell you about today. OPT-SMC, standing for Optimizing Seasonal Malaria Chemoprevention. Would you like to know how this project came about? OPT-SMC was a response to an urgent need of universal access to core malaria interventions and aiming at full coverage. And focusing on one intervention, SMC, the project was built in 3 principles. Firstly, there is no one global solution for poor coverage. Barriers differ by context, and implementation research is needed in each SMC country. Secondly, research findings are more likely to be implemented when the national programs are involved. And thirdly, it is important that lessons are shared across countries. So therefore, thanks to the European and developing countries' clinical trial partnership, OPT-SMC was set up as a partnership with the 13 national malaria programs that are implementing SMC. And it is coordinated by Professor Jean-Louis Ndiaye at the University of Thies, with the technical support from London School of Hygiene and Tropical Medicine, and our 2 hosts today, TDR and MMV. The objective was to support technically and financially the national program to identify SMC research priority questions, lead implementation research, and then put findings into practice. So despite challenges in coordination, OPT-SMC has achieved impressive results in 4 years, helping countries to either monitor and evaluate, explore barriers, implement adapted strategies to overcome these barriers or to adapt target groups. And as examples, our colleagues from Ghana has assessed during the COVID-19 pandemics, SMC coverage and factors that are associated with uptake and adherence. We also have our colleagues in Nigeria who conducted qualitative study across 5 states to understand community attitudes and barriers. Guinea and Burkina Faso also explored barriers, focusing respectively on mining zone and urban area where coverage were reported to be low, and they are now working all together with stakeholders to pilot adapted strategies. We also have Cameroon and Mali who have explored how they could improve adherence to 2nd and 3rd dose of amodiaquine. And all these experiences have revealed critical insights, notably addressing mistrust and concern about safety, involving local advocates, and recruiting local distributors are among key to success. Now we are entering a new phase of malaria prevention with the malaria vaccines. But for me, the question remains, how to achieve high coverage? Malaria vaccines are likely to face same challenges as SMC, And I'm convinced that the approach of OPT-SMC is one that could be considered to support the implementation research that will be needed. And hopefully, we will soon have exciting announcement along this line with a new project to support country optimize the vaccine delivery. Today, I want us to remember that the fight against malaria is evolving. But with the combination of right tools, with research, capacity building, and global collaboration, we can envision a world where millions of children, where malaria is no more a leading cause of child mortality. Please, let us seize this moment and push forward to our shared mission to save lives, eliminate malaria, and so I can realize my dream and start a new job career within the next decade. Thank you.
Fantastic. Thank you. Thanks, Fatimata, and let's all dream on. We put ourselves out of work. Some of us in the audience, I think it's still going to be around when we go out of work, but you're our target. So next I'd like to call Justin McBeath. Justin is the CEO of Innovative Vector Control Consortium, and he's going to bring us the perspective from insecticide-treated nets. Justin, the stage is yours.
Good morning, everybody. I look out over this sea of faces and I think I see probably a handful that are actually who I would sort of associate or know as part of the vector control community. And so I'm very conscious that there is probably a little bit of a dearth of kind of knowledge and awareness of some of the things which actually exist and what we're doing in vector control. I will speak a little bit more broadly than around nets, but maybe just to sort of start off and put a bit of context. I wanted to reflect on the Sam Batt paper from 2015, which we talk about a lot in the vector control community. It may not be so familiar to some of you in the audience here, which is essentially the contribution of vector control and the use of insecticide-treated nets and indoor treatments with residual insecticides towards the reduction in malaria cases between 2000 and 2015. And ultimately, vector control contributed or was attributed to 80% of that reduction. Vector control is obviously, therefore, a very significant and highly important part of the malaria story. So, that being said, that was 10 years ago. That was a paper reflecting on the work between 2000 and 2015, and we're 10 years on now, give or take. One of the most pervading challenges has been resistance. It's one of the reasons why the organisation I lead up, IVCC, is one of the reasons why we exist, is obviously to look at generating new insecticides for use on nets. We've seen tremendous progress over the past 5 to 10 years in terms of the advancements in that area to address resistance, not just from the nets perspective, but also in indoor residual spraying. So we've seen 3 additional modes of action for indoor residual spraying. From an IVCC perspective, we kind of feel like there is a good choice of tools and availability of different modes of action to support where that need is for malaria prevention with the use of IRS or indoor residual spraying. The challenge around nets, we've seen in the last 2 years the introduction of an additional mode of action for insecticide-treated nets with the chlorphenapyr dual AI nets, first from BASF and then a couple of others which have followed. We've seen the impact that that's had with the RCTs which came through the New Nets project, and the 50%, give or take 50% improvement from the Benin and Tanzania trials over and above that previous standard of care of pyrethroid-only nets. So there has been significant advancements in terms of additional mode of action for nets. There is a pipeline, and our focus, it's not really surprising in terms of our focus, is still to expand that range of modes of action on nets. We would expect to see, and we hope that there would be probably an additional 3 modes of action before 2030, touch wood, fingers crossed, everything going according to plan. Obviously addressing that need to address resistance. But these are indoor tools. IRS and nets are targeting indoor transmission, and we have this other pervading challenges and emerging challenges around either outdoor transmission, for which there are no current tools available today. There's a parallel symposia which is running at one of 2 additional vector control symposia, which is one of the reasons there's probably absence of vector control people in the audience here. But one of those symposia is actually presenting a suite of results on the ATSB, the targeted sugar baits, which didn't go according to plan. And the results which will be shared is essentially that the major trials which were intended to show impact on malaria didn't. I use that example essentially to say that there are a range of innovations we're looking at. There are challenges in addressing and solving some of these vector control problems. There's certainly no silver bullet. And I want to reflect a little bit in terms of then the context with vaccines and drugs and other things, and quote a line from the WHO malaria guidelines in relation to the RTS vaccine, where the 30% reduction in severe malaria cases, which was attributed to RTS, was in a context or a basis of access to drugs, vector control, and diagnostics. And my message really here today is around this complementarity, and I echo George's comments from earlier. The essential need for this complementarity approach. Certainly there's no silver bullets in vector control. There's very positive progress with nets. We're certainly addressing that challenge around resistance. We're not solving the outdoor transition challenge at the moment. And ultimately, these decisions need to be made at a country level in terms of the prioritization of resources, and there needs to be the right kind of information generated to support that decision making. And we all need to talk to each other in terms of what we're each doing to understand how those things fit together. And I'm going to stop there, bang on one. Thank you.
Thanks, Justin. Fantastic. Yeah, did you hear that? Could you please just move along the rows a little, then there are people standing at the back, that would be great. There's also chairs at the front here. I promise there'll be nothing thrown from stage, so please come and, well, no, maybe I shouldn't promise that yet, but I'll try and prevent anything being thrown from stage. So, great, thanks. So we've heard now about IPTP, we've heard a bit about seasonal malaria chemoprophylaxis, we've heard a little bit about new innovations for bed nets. So the next couple of sessions we're going to talk a little bit about vaccines, and of course we have not one but 2 potential malaria vaccines to discuss. And so the first of our speakers here is Dr. Ashley Birkett. Ashley is the Global Head of Bacterial and Parasitic Diseases at PATH, the Centre for Vaccine Innovation and Access. He's going to talk a little about the RTS S vaccine. Thanks, Ashley.
Thank you, and thank you for the opportunity to be part of the panel here today. So I'm going to start with a quick poll. If you're raising a child in a malarious region of sub-Saharan Africa, how many of you would be interested in providing your child with a tool that's now been shown to reduce overall mortality by 15%? Quite a few of you. Maybe some of you aren't parents. But those are the sort of data that we're seeing now from the early implementation of the malaria vaccine in sub-Saharan Africa. And as you know, the vaccines are starting to get rolled out. There's really unprecedented demand in terms of vaccines that we've seen in the other vaccines that we've worked on, really unprecedented demand, and we expect 16 countries to introduce the vaccines by the end of the year, and about 30 or so in total are showing interest. So really huge demand. First significant new intervention recommended by WHO in over a decade. So really an exciting time. But I think as you've heard from other speakers, this is not a silver bullet. This is another tool, another imperfect tool, which actually gave relatively modest efficacy in clinical studies. But in real-world settings, now we're getting the real data, another tool that has potential to be very impactful, despite those modest data from clinical studies. And I want to talk a little bit about that because, when we develop vaccines and we introduce them, we typically do that with limited data. We have phase 3 studies that are very controlled conditions, sort of artificial. No child should die from malaria, especially in a controlled setting. Yet when we roll the vaccines out in these real-world settings, we're seeing really quite impactful results. So there's still a lot we can learn. I think that's really a key point. We don't know everything about these vaccines. We still don't know how to best use them. We're still learning. And I want to give you 3 examples of how we're learning and new data that will be coming over the coming years, which really will continue to help us to maximize the impact from this new innovation. So the first one is around seasonal vaccination. So we know these vaccines have relatively high level short durability. And what happens if we implement the vaccines just before the rainy season, when children are most at risk? Well, those studies have been done, and we have data now that extends over 5 years that shows that actually, if you implement the vaccines just before the peak period of risk, you can actually increase the efficacy by about 50%, up from about 50 to about 75% efficacy, which is quite significant. Challenge being, that's a difficult schedule to implement. So we're not seeing any of the countries so far actually implement the vaccine using those schedules, despite the fact that we can improve efficacy by 50% in the short term. So these are important lessons in terms of implementation. Second one, another key challenge of the vaccine is it requires 4 doses, and the 4th dose in the second year of life. Vaccinating children in the second year of life is challenging. And so we're going to have data over the coming months which will tell us how important is that 4th dose. Do we really need that 4th dose? And if it's proven that it's not essential, then that again could ease implementation by really condensing everything into the first year of life, which would be very advantageous. And then the third point I wanted to make is really around the power of the EPI platform, the immunization platforms which were established 50 years ago and have been responsible for preventing the deaths of over 100 million children over the last 50 years. It's really a remarkable platform, and really one of the key assets of vaccines is we have this amazing delivery platform so that with new tools, we can get to quite high levels of coverage quite quickly. So there are ongoing studies to look at the ability to leverage those contacts with the delivery of other interventions. We know that we can deliver bed nets through those contact points when children get vaccinated. There's going to be data coming over the coming years on perennial malaria chemoprevention. What about if we give those low-cost drugs at the same time as the vaccine so that we can provide some protection to those children while their vaccine-induced immunity is building through those multiple doses. So these are the types of learnings that we still have, and we're continuing to figure out how to best use the new tool in the context of the other tools and leveraging the immunization platform. My final few seconds, I just want to make a few points on next generation vaccines. We need to continue to innovate. So 2 things we need to do. We need to continue to make sure that these vaccines are going to be scaled up and available to all children that need them. We might need 100 million doses or more of these vaccines over the next 10 years or so. So huge demand. This is going to be expensive, and obviously cannot come at the cost of the other tools that have proven to be highly beneficial over the last several decades. But we need to continue to innovate. We need new tools. We need better disease reduction vaccines that can provide better clinical benefit against disease and death, and ultimately strive for vaccines that can break the cycle of transmission and can work in all age groups, that can ultimately help accelerate elimination and eradication efforts. So as a parent of children who've made it through their teenage years without the fear of dying from malaria, I really hope that we'll see those investments over the coming years to both ensure availability and access to these great new tools that we have, but not at the cost of the tools that we're already using, and then also continue to innovate future vaccines, reduce the burden of death down to 0, and eventually our shared goal of accelerating elimination and eradication. Thank you.
Thanks, Ashley. And another speaker keeping absolutely on time. They're very professional, or I'm very scary, so I'm going to thank them for their professionalism at the time. If you are looking for a seat, there is a row down here. I know Christian Engweder is sat here, but as a fellow Australian, he's relatively well house-trained, so please do come along and sit by the side of him. Okay, our next speaker needs very little introduction. Professor Adrian Hill is director of the Jenner Institute of Oxford University, which obviously hit massive profile during COVID, but he's here today to speak about one of his career passions, which is the malaria vaccine R21. Adrian, pleasure to have you here.
Great, thank you for inviting me. Some of you noticed I came in a little bit late. I was phoned at precisely 7 o'clock by the BBC saying that they'd like to know what my frank and truthful opinion was on the appointment of Robert F. Kennedy to head Health and Human Services. To which I said, well, if you really want a truthful opinion, can you just wait till I leave the country? So, malaria. You've had a fantastic description of where vaccines are by Ashley. I'm going to pick up on that and talk not about RTS S, but new malaria vaccines, one of which you've heard has been licensed and rolled out in the last year, and it's very exciting, and we think will have really big impact. But also about new vaccines coming along, which are equally exciting. And I genuinely think that in the next 3 or 4 years, we will have several vaccines in combination that will have very meaningful impact. So let's start with R21. Way back, around about 2010, we took a hard look at RTS S, which was then the leading malaria vaccine, and realized that about 90% of it is hepatitis B, and about 10% malaria. And tried a few things to see if we could change that ratio. And by using a new methylotropic yeast with a strong promoter for the transgene, managed to make a particle which is covered in the malaria antigen, the circumsporozoite protein. So that looked immediately as if it might be promising. In mice, that was confirmed. We took it forward into clinical testing fairly quickly in our own tiny manufacturing facility in Oxford. And today, it is not only approved by the WHO and being rolled out in many countries in Africa, but we have excellent data showing that over 4 years in a phase 2 trial and over 3 years in a phase 3 trial, we're seeing higher efficacy than with any previous vaccine. So RTS around about 50% in a year, we're around about the 75% mark without seasonal administration, which is good if you have a not durable vaccine. The whole point of increasing the density of the antigen on the nanoparticle surface is to increase the avidity of the antibody responses that you generate. That seems to be working, and to increase durability to the duration that you see with other non-malaria vaccines. So that's very exciting. Look out for those data. Secondly, the first vaccines that were tried and people thought would be logical to deploy are blood stage vaccines. And there's been extraordinary progress just in the last 6 to 12 months with results from my colleagues' lab, Simon Draper's, not ours, but in Oxford, and showing high efficacy reported in Rwanda at the MEME meeting just some months ago with RH5, a new blood stage vaccine that is remarkably conserved and protective. And look out for those data. They haven't been published yet, but they are really exciting. And it's very important that we have an anti-disease vaccine slowing down parasite replication in the blood and not just antisporozoite vaccines. And I think that the combination of those two, R21 and RH5, which are in trials in children in Burkina Faso, led by Professor Tinto as we speak, will be the key tool in the next few years with vaccination to make a real impact on disease. And I'm not talking about 50, 60, 70%. I think we're up in the 90% range if you do the calculations of what's going on biologically, but wait to see. It won't take very long. So that's the second advance. The third one hasn't happened yet, but given the pace of development in malaria vaccines and the fact that suddenly we have credibility because we academics can license vaccines, this is going to move very fast. And that is adding a transmission blocking component, a third malaria vaccine, into the mix. Because you want to control malaria transmission. The principle has been proven by Patrick Duffy and many other people, and Patrick's vaccine is one of the several that is being mixed with R21 right now to see how that will perform in clinical trials, I think first in Sierra Leone in the coming months. So if you put all those three together and do even very simple calculations of what should emerge, it looks really exciting. The problem, as Ashley mentioned briefly, is you've got to get somebody to manufacture these. And we have been extraordinarily lucky in getting in partnership with literally the world's biggest vaccine manufacturer. They're not in Europe, they're not in the Americas, they're in Pune in India. They supply most of the vaccines to Africa. And Dr. Poonawalla, who founded the company, is hugely committed to controlling malaria. You saw how quickly they were able to move, not just with COVID, but with R21. They've taken on RH5. They're taking on 3 transmission-blocking vaccines at the moment till we figure out which is the best. And what's really important are 2 things. Firstly, their cost of goods. If you manufacture at a 1 million dose scale, you're going to be looking at least tens of dollars per dose. That's too much. If you're at a 1 billion dose scale, as they did with COVID, and hopefully will do with malaria before too long, you're down to single figures, or maybe even less. The average vaccine in EPI costs cents, not dollars. You've just got to get to scale. So taking on 3 malaria vaccines isn't crazy. It increases your impact. It allows serious elimination campaigns to start in the coming years, and eradication, I believe. Of course, with all the other tools that you have heard about. So let me leave you with the thought that some of you in this room will see malaria eradicated. I don't know about people of my generation, but we live in hope. But we have tools that we didn't have before. We've figured out a lot about how to vaccinate against this parasite. We have fantastic complementary tools which must be used in those elimination campaigns. And things are moving fast. Thank you.
Thanks, Adrian. And he's obviously more diplomatic than me. I should have thought about getting out of the country before I started joking about the administration. So thanks for that. Now we're going to move back to medicines, but we're going to talk a little bit about medicines and how they can be combined with future interventions, picking up that last theme of Adrian. And to speak on this, Dr. Cristina Donini. And Cristina is the Head of Research and Early Development and Modelling at MMV. Cristina, the floor is yours.
Well, I think there's a lot of excitement actually in the room. And I was reflecting back sitting there. My first ACMH was 10 years ago, exactly to the date, in New Orleans, as a newbie person in global health. And I think that back then, we would have not dreamed to be here today to actually talk together about vector, vaccine, and medicine, that it can be used together. We're talking about combination of vaccine and drugs. We're talking about combination of vaccine. We have innovation in the vector control. So I think that we are at a fantastic moment and juncture in the global health community and the malaria community. I like to see it as a toolbox. So if I go back 10 years ago, that toolbox was pretty empty. I mean, there were few interventions, particularly in the prevention space. And then today, we do have more. And if, as a drug developer, I have to look at the seasonal malaria chemoprevention with drugs. So it's a combination of sulfadoxine, pyrimethamine, and as it is a very cost-effective tool that we have in hands. And if we look at the success of SMC, we started with partners in 2012. And in 2023, we had 53 million children that were protected with SPAC, which is a giant success. And it was not, it was a big undertaking from the community and from the consortium. And that cost-effective drugs, it can be actually, it doesn't need any cold chain, and it does show protective efficacy of 75% according to WHO, 88% in a controlled clinical trial. So it's pretty good. And we are thinking about optimizing it. We're thinking about combining it with vaccine. We're thinking about expanding the age and the geographical reach. So we're thinking about broadening that population. And so you must wonder, why do we still need other drugs? Why do we need new tools? If we look at the gaps that we do have today, I think that we're still thinking about, we need to think about pregnant women. Margaret talked about it. We need to think about first trimester. We need to think about migrant workers. We need to think about different strains of the Plasmodium. And so at MMV, we've been working in trying to simplify the regimen. I think you all know that we're working on single dose, but we're also trying to look at SMC and looking back, how can we simplify that regimen? Fatimata talked about adherence. Adherence, it can be a problem. And so we're very excited about new tools coming along the way. It's early days, so we're working on a long-acting injectable drugs. So we're thinking about combining two drugs. We have to go into combination. We think about resistance. So combining two drugs that actually can be given in a single injection, hopefully lasting for an entire season. No cold chain needed, cost-effective. The drugs are cheaper than biologic, in essence. And so we've started this with the partners several years ago, and now we have the first study that has started in September. So we have the first in human ongoing with an atovaquone derivative, so we all know atovaquone, and we have gone under the first cohort. So far so good, looks promising. Second cohort is just starting. So it's very early days, and I'm trying to tame my enthusiasm. I'm very optimistic, but I'm glad that I'm not the only one. Adrian just said, you know, we live in hope, and I think we need to still living in hope. The second compound will come next year, so fingers crossed we should be in patient exploratory study in 2026, and that could be another transformative tool that we're gonna add into that toolbox that will have simplified regimen that could help with adherence, that could actually broaden the population that we want to reach. You need to be ahead of that curve. We keep talking about bending that curve. I think that to bend the curve, we need all the tools that we are discussing today. We need to work together as a community of malaria researcher to make sure that we don't leave anyone behind and everyone can be prevented from this disease. Thank you.
Thanks very much, Cristina. Another terrific angle on this story. And I think we're moving towards Fatimata's hope that she's going to be able to get rid of malaria by the end of her career. So we'll come back to that at the end. But now we're going to go first to Dr. Seydou Doumbia. Seydou is the Dean of the Faculty of Medicine at the University of Sciences, Techniques and Technology in Bamako. And he did whisper to me a little earlier, he's one of the products of our earlier TDR schemes, so it's very fitting that he stands here on our 50th birthday. Welcome to the stage, Seydou.
Okay, thank you, John. Good morning, everybody. And I'm so happy to be here. And in fact, 30 years ago, I got a fellowship from TDR to come study at Tulane and to go back strengthen malaria research capacity in Africa. My task been made easier because everybody has talked about new tools, and we are always excited to have new tools, and all these tools are exciting, and we hope that they will contribute to eliminate, and they even perform better when they are combined. But still we have malaria persisting in Africa. I call it stubborn malaria. With all these tools, but it's still persisting. So why? Any of these tools has some barrier. You have access. I think they have been talking about that. You have how to deliver them, how to make donors investing to make them sustainable. So how to make people compliant to the use of these tools. So all these are barriers to make them successful. So I'm going to give some just story about some of these barriers. And when I was a medical resident, maybe 40 years ago in a small village, and in fact, I was a resident working on curtain impregnated insecticide, curtain impregnated with insecticide, which was the early tool for vector control. And so I was giving chloroquine to mother the first day and give them, okay, you can give the rest at home for 3 days. And everybody was happy to have, for the first time, a young physician in the village, and we reduced malaria. Every day I receive, in a small village of 600 people, every day I receive more than 40 children to treat them during malaria season. So when I finish, I did not want to leave, of course, that they did not want also. But the last day, every family brought chicken to me. Because they were happy with what I have done. But the big surprise to me was also they brought the rest of the chloroquine I gave them. And telling that thank you so much. When we have used the drug, so the children in recovery, so we are happy to give you the rest of the drugs. So just to tell you how important is the implementation research everybody has talked about. We have the health worker, we have guideline, we have also mind lines. You can see how the health worker perform by not being compliant even to what we have been talking about. So it's very important that we get implementation research to make sure that these tools are well delivered to get success. And we also need to strengthen capacity for implementation research. And then thank you again, TDR has supported 10 universities across the world for postgraduate training in implementation research. And I was fortunate to be part of this network with Senegal and other African country, Ghana. And it's very important that we leverage, we train a critical mass of people, and that's so that implementation research be integrated part of all this program. Thank you.
Thanks, Seydou. Fantastic. So our final speaker is Keziah Malm, and Keziah is a program manager at Ghana's National Malaria Elimination Program. So we've been talking about the tools, where the rubber hits the road. This is where it happens. So Keziah, please come and give us your perspective.
Thank you very much for the introduction, and thank you very much for the invitation. Yes, like John said, I'm from Ghana. Ghana is one of the countries considered as one of the high-burden malaria countries in the world. As a country of 30 million people, we are recording over 5 million malaria confirmed cases in a year. That's 1 in 6. So indeed, malaria is a challenge to us, it's a problem. So we are very happy to see all these new tools coming up. Vaccines, medicines, vector control tools. But as a program, there comes the issue of how do we do it? How do we combine it to make sure that within the limited resources that we have, people who need their interventions get them, and we are saving on costs, we are saving on the time of the health worker, and hopefully we'll be able to achieve the dream of Fatimata. As a program, integration of these tools are very important, not just for the national program in terms of making sure that the limited resources go around the prioritized tools that we have. And that's why as a country, even though we are part of the high burden countries, we have set up a strategic plan that's looking at subnational elimination. And in that, we are looking at how do the implementers not get overwhelmed. The health worker wouldn't have to go to the house so many times to deliver one intervention after the other. the mother of the child doesn't have to go to the health facility several times for one, two, or the other. And how do we make sure that the child is not being injected here, having a pill down the leg, also at different times? So we have integrated the malaria vaccine, the new one. Ghana was one of the first countries into our routine surveillance. And I think our colleague from Path mentioned how effective the routine immunization system is. And as part of our efforts to integrate, we need to be able to appreciate who has the strength to do what. We are talking about who, it's not only in terms of persons, it's in terms of which system has the strength to be able to take on new tools. When we are talking about integration, it's not just a matter of adding on. What we have learned from our previous attempt at integrating some of the malaria interventions is that integration really demands a bit of first disintegrating. You need to understand what each of the interventions has as a plus, which part of the intervention can be added, so that ultimately your goal of making sure that there is improved efficacy, there is improved effectiveness, you have a higher efficiency both on time, human resource, and finances are achieved. If you just add on, the likelihood of breaking the camel's back then happens. So one of the things that we did is to make sure that we start planning early. And planning involves not having people at the national level just talking and sitting together. What we did recently, where we integrated mass campaign of ITNs into SMC, was going to the regions, the district, talking to them, bringing up the ideas, taking their ideas as to which aspects of these interventions we can integrate and which aspects we have to leave them separate, and we have to leave them separate. Then they went back to their district to talk to their district directors. So these are people who actually implement the interventions. And there was a lot of back and forth for us to redesign what we had thought of as an effort as integrating two tools to save on resources. And it was done successfully. And thankfully, an intervention that could have taken like 12 days separately, we were able to do it in 8 days. It saved on the time of the health worker, it saved on the time of the parents, it saved a lot on resources, and we're able to increase SMC rounds from 4 to 5 and even get higher coverages with mass campaign. So I'll say that integration is important and possible, but it's not just adding interventions together. It's an effort that requires deliberate attempts, starting planning early, and really sitting down to see what will really benefit us if we add on, and what is it that we need to leave for them to stay separate. Thank you.
Thanks, Keziah. So we'll move on to some open questions. So I'd like to invite the panel to maybe take the stage. While they're doing that, we have a live mic here. So if people have questions for the panel, please come around to the mic. Don't be shy. I probably don't need to say that to this audience a few days into the meeting, but please do come around to hear. But perhaps while people are getting on stage, maybe I'll come back to that last talk, just as we're getting settled, because my experience is everybody loves coordination. Nobody likes being coordinated. So we talk about integration at the program level. It must be a nightmare sometimes. Do you want to give us a little bit of your insight, how you manage that, and what we as a community with malaria can do things better to make your life easier?
Sure.
Okay.
Yes, sometimes it can be a nightmare. Is it working?
I think so.
Okay, it can be a nightmare, but one of the things that is helpful as a program is first have a very good strategic plan, which is done with all partners involved, so that your nightmare is reduced. And once partners are involved, we don't get partners trying to do things differently. And that is the beginning of the planning phase. So the planning has to start early for us to all understand that we are doing this way and doing that together. And involvement of stakeholders, not just at the national level or at the regional level, but at the community level, in terms of people who would use the tools, is also very important. Identifying the resources that are needed to make integration possible is key. And resources, I'm not just thinking about money, but resources include really, really human beings. And sometimes in most of the interventions that we do, we are looking at the tools, but we sort of put the human resources at the backbench. But they are I keep saying in our country that the human resource is the #1 tool. So having that thought through the integration process and making sure that you are putting that on top. Which human resources are going to do it? How are they going to do it? What capacity is key to making sure that integration is very important. And we should never, ever forget why we are integrating, because sometimes when we miss that, we miss it along the whole process, to make sure that as much as we integrate, the final goal of the integration is not missed. Thank you.
Great, thanks, Keziah. A really important reality check for all of us who are looking at pieces of the puzzle, and you've got to really be looking at the whole game here. Please, don't be shy. I restricted everybody to 5 minutes, and they could have spoken for an hour, so try and find out what would have been in the other 55 minutes for any of these talks. David?
I'll try not to be shy. So I think this was really wonderful, and I think we're seeing the convergence of all these tools that can really change the landscape over the coming years. So I really share and I'm encouraged by your enthusiasm and optimism for the future. So we have seen in recent years, obviously, since 2015, that despite the tools we have, like COATM being effective and good insecticide-treated bed nets and vector control measures, that, as we know, the burden has gotten worse in sub-Saharan Africa. And so I think this is a great panel to ask the questions. What do you see as the major drivers for why it has been hard in the past decade to continue the downward trend, and on the flip side of that question, what tools do you think would be the most effective in your local regions that could really sort of reinitiate the drive towards malaria elimination? Thank you.
Great question, David. We have to be nice and let him have a question. He's the next president, so if you want to get invited back to Toronto, he's the man to suck up to at the moment. I think that would be a great question to take on a couple of different levels. I think maybe let's start with Seydou and the angle of implementing within countries. Then maybe we can move into anybody else who wants to take this about the development of tools. But Seydou, please.
Okay, well, I see several factors. One of the easiest one is an example of sustainability. When RTS was implemented in some district in Mali, so we saw a very nice decrease of malaria incidence. And then same thing with Jeff Sachs' Millennium Village in Joro. So every health indicator were very improved. And when it was stopped, then we see an upsurge. So you see how sustainability in these intervention tools make the difference. Another way, that's also why I emphasize on the implementation part. We think everything is good, but how do we deliver this intervention also still make difference? We make one investigation on IPTP, asking women what they think about the drug we give to them during antenatal care. So they said, they merely give us, we merely swallow, meaning that they receive anti-malaria drug, nutritional supplement, and they don't know how to do with. And so it doesn't make any sense to them. And the other issues also I've been talking about is the health workers or even the program, how we combine always. SMC, you give SMC for 5 months, and we realize that at the end of SMC, you have at least 20% of people who carry the parasite during the long dry season, and then when the rainy season starts, so we have not only problem of delivery, combination, sustainability. So those are just some elements for me which are barrier to elimination. Thank you.
Thanks, Seydou. A really important perspective from that. Maybe we just counter that a little bit with one of the speakers who spoke about some of the interventions coming in. Actually, is that an accident that you've got that in your hand? Or
It is a complete accident. It's like a
Everybody
hot
else,
potato.
Everybody else took a step backwards. And
Yeah,
you're
but I'm happy to say
but we'd be delighted to hear from you.
Yeah, well, I think just coming back to the point on delivery and the importance of delivery, I mean, we can have the best tools in the world with the highest efficacy in clinical trials, but if we can't deliver them, they're not going to have the impact. They need to be deliverable, they need to be affordable. And I think just, again, to come back to the point of the power of the EPI platform, even in in very poor countries where resources are very limited, it's not unusual to see 85% of children getting their vaccinations through the first year of life. And so we know vaccines are a great tool for combating infectious diseases, but I think we need to think about that platform and the value that that platform brings, that we can relatively quickly slot new tools into the platform. And if we're smart about how we develop the tools and the schedules that we use, they can quite quickly drop into that platform, and we can get to 50, 60, 70% coverage quite quickly because we have the platform in place. So I think, yes, vaccines are fantastic, but we have this platform. And then how can we leverage that platform to then co-deliver other tools? Why not deliver a bed net when the children are getting vaccinated? Why not give perennial malaria chemoprevention when the children are getting their first and second dose and the vaccines are not yet providing full protection? What we have to strive for is vaccines that can give us solid protection based on contacts in the first year of life, right? So right now, we know if we continue to boost the children the second year of life, the third year of life, and the fourth year of life, we can extend the benefit of the vaccines out further. But to Adrian's point, what we want are vaccines that we can give maybe 2 or 3 contacts in the first year of life, and then we're going to have durable immunity that can potentially last through the first 5 years of life, and then that access and contact challenge that we're faced with many of the current tools could be mitigated. So that's really one of the goals of future vaccine programs.
Thanks.
I would say that from a drug perspective, I think simplifying regimen is very important. If you simplify the regimen, you will increase that adherence. And of course, from a resistance perspective, I think that we understand a little bit better maybe what we need to do and which kind of drugs we need to combine in order to tackle that resistance. And I don't want to talk about the irresistible. We don't talk about irresistible anymore. We call it refractory to resistance or high barrier to resistance. But, it's a very high bar. But I think that, combining drugs that maybe have medium or risk of resistance, propensity to resistance, maybe that is the way to go. But to me, simplifying the regimen, this is why we're very excited about this long-acting injectable. It's one shot with 2 drugs in it that can give you a duration of 6 months, and and it clears the parasites. So you start targeting that parasite reservoir that we are now looking at. Pregnant women, they've been neglected, particularly first trimester. So there are still a lot of gaps that doesn't let us bend that curve.
Might comment on something a little bit more basic, which is ultimately, is the demand outstripping the resources which was available to keep up? I mean, that's got to be a significant contributing factor to that gap. And when we look at, looking at the example of nets, the introduction of the new dual AI nets, clearly a significant improvement in efficacy, but there's also an increase in cost, and something has had to give. And we've heard from Seydou, there's Mali's one country where IRS programs has basically there's decisions made around prioritizing dual AI nets versus IRS. So there are trade-offs, and I think do we have a clear understanding about that kind of pace and increase in demand, and whether or not we actually really got the resources to keep up, and that's got to be a contributing factor.
The way I see this is slightly different. I think you've got 2 options. You carry on doing what we're doing at the moment with incrementally better tools and better control and hopefully impact in every country that has the resources to do that. And you carry on spending around about $5 billion, not million, dollars a year doing that. By the way, just on the vaccines bit, a tiny fraction of that is buying vaccines. The other way of doing it is to decide you're going to do a pilot program somewhere and find out what it actually takes from all these interventions we've heard about in combination to locally, regionally eliminate malaria. We don't know that. Many of us think it can be done, but we need to find out. But the point is that if it's feasible, and okay, it might take $15 billion to eradicate in high transmission areas and have a big impact on child survival, we need to know that soon and to do a costing, because it looks to me like great value for money. In the next decade, if we carry on, we're going to spend 50 billion, 50, not 15. So at some stage, we've got to decide, right, it's good enough, let's go in, let's raise the money. And by the way, it's been done before. EPI is there because financial guys got together and figured out how much it would cost to basically do EPI and buy vaccines at scale and at very low cost. And childhood mortality, as you know, halved from 2000 to 2015 in Africa, mainly due to the introduction of vaccines. So we need to think big.
Thanks, Adrian. And a really great point about, firstly, the cost effectiveness. We all know that's going to be the argument for anything in the end with this, sadly, but that's going to be the way to go. But that point of one size will not fit all, and we really need to contextualize within regions and within countries, in fact, and probably within districts eventually, and how we set up to do that. So maybe that's a really good opportunity to give the speaker who hasn't spoken yet, Fatimata, who's been out there with Malaria SMC, and give your perspective of how we can manage to really localize these events to make them cost effective and effective in controlling disease in country.
Thank you, John. So I totally agree, because I'm wondering less about effectiveness, but for me the main challenge is how to deliver. Because once we have an effective tool, the first question is how to achieve coverage. And for this we need to move away from the one-size-fits-all approach, knowing that each country has its own context, so barriers differ by context, and we need to take into account the local context when we are planning our interventions. We need to take the community involved, so community engagement and ownership is also something that is very important, because in all our studies we did with the SMC project, this is what came out: mistrust and concern about safety. And every time we use local distributors, this is something that helps to adherence of the treatment. And another thing is also we need to align national priority with research. And for this, we need to promote collaboration between the national program and the local research institutions in order to make evidence-based decision-making. So I think, this is the two things I think would be helpful to achieve coverage and to be able to take full part of the effectiveness of all the tools we have. Thank you.
Thanks, Fatimata. And just on that last point, I was going to open it again, and please do come and grab the microphone, because I've almost used my entire word content for the day, so I'm going to go quiet in a second unless somebody else starts speaking. Those of you who know me realize that's not a joke. But that actually did trigger me of how we managed to connect the research in countries and researchers in countries with the national programs. And I'm going to come to the other end with Seydou, because I know this is of an interest to you. How do you get your program within country to be working with the national programs and making sure we're using all of the intellectual resources within the country to address this problem?
Yeah, I think Fatimata said research can help to provide evidence in real time to the program. So research also need to understand what are the questions. So therefore, I believe first that we invest millions of dollars for making these tools, but very little for research, because everybody thinks that the research is, we finish with the research phase because we have proven that the tool works. So the next step, how to make the community make it happen, that's the next stage of implementation research, which require researcher and the program to work closely together to find the best method, what's the best method to deliver, what the best method to make, to communicate with people. If I was giving the chloroquine to the people, and they were contributing to the resistance without knowing it, because they just give the first dose, the second dose, the child is fine, or they believe that the more drug you give to the kids, so you're gonna cause harm to the kids. So all these aspects are not part of our intervention, so it's left out. So that's why it's very important that researcher and the program work closely together, and also, as my colleague said, Alan said, the cost effectiveness. So to make sure that people understand that the benefits of making the change, the benefit of investing in this, because sometimes you're wondering if you are really serious about malaria elimination, because we invest just a little bit and then it doesn't continue. And then malaria take advantage of persisting. So yes, it's, I think the example we have is regularly meeting with the program, identify the key barriers and propose some solution, test this solution and see how it can also improve the delivery in real time.
Thanks, Seydou, and bringing up a really important third part there, not just about the researchers and the program implementers, but the community and how we engage them optimally and really work with that. And one of the exciting things we've been doing at WHO, in fact in TDR for the last few years, is working with social innovation groups and seeing how we can put research into their hands to be able to get grassroots level evidence-based implementation here. So another symposium there altogether. Okay, we have about a minute for each speaker left, so any questions? Is somebody going to come to the mic? If not, yes, please.
Hello, I'm Corinne Goufford, London School, and I just have a question around how you see financing, because we have all these tools, which are wonderful tools. They all have their limitations as well, and ideally we may want to deploy all of them together, but that's not possible because of the financing. So there's also the question of using modeling to be able to target tools based on local context. So I just want to hear your perspective on how modeling can be applied to just make sure that we are getting the optimal outcome from using these tools, perhaps in combinations in different settings. Thanks.
Thanks. Who'd like to take that?
Thank you. I think it's a very important point, and we're working, at least at MMV, with SEPA. You're absolutely right. We need to understand where we're going to deploy those tools, because I think we cannot deploy it everywhere, right? So having a model that tells us where will we have the major impact for a specific tool will actually help us in optimizing the funding. And I don't know if there's any funding people in the room, but financing is going to be an issue. And we all know, I think here, that we will need to optimize resources, work together as a community to make sure that we have the right tool in the right settings.
Well, I do believe also to modeling in terms of research. That can be the contribution of research. Giving one example in one of our study sites, when we started in 2012, so we used to have like 60% of the children who were carry the parasite any time of the year, and then 15 years later, we brought it to 10%, but it's still persisting. So in terms of modeling, with all this intervention, I did not talk about all this combination of intervention we have done on the site. So with all this intervention, if we do projection for how long we're gonna get to zero, and if we get to zero, what do we need to keep it to zero? So I think modeling can help us to guide some of the action and through research.
So just a comment on Corinne's thing about modeling. Yes, modeling is very important in helping us predict how things will work. But I always say that modeling is as good as what data you put in. So as much as we want to improve on the modeling, we also need to work on providing the data for the modeling. And I can use my country, for example, where we're modeling the vector control tools, and we didn't have data for larval source management, which we believe is an important aspect of the toolbox, because that data hasn't over the years been provided. But so modeling is good, but there is still a bit more we need to do to make sure that the modeling results are telling us what is actually going to happen, because we've had experience where we had two different models telling us two different things with the same data that we have. And also to comment on the researchers working with the program to make sure that we get the best. I think in terms of integration, it shouldn't only be limited to implementation, but it should also include integration of researchers in the country, because sometimes what we see is that some researchers, I mean, depending on the partners they work with, maybe doing almost the same thing. But if we integrate and we work together, we'll be able to optimize the resources. And we had to do it with our researchers who were working on resistance in the country, and realized that quite a number of them were doing resistance in one form or the other. So we came together and decided that if you are collecting the data, sorry, the samples, this other person doesn't need to go collect the same samples. So you collect and we share. You collect, you finish your part, and we share. And that saved on resources for the others. And we're able to push those resources to do other things. So, and once you start with a program in terms of planning, it makes it much more easier for the program to accept the results, rather than going ahead and sometimes only coming to the program for a letter of to the ethical review board. And when the results come, it's difficult for us to appreciate, because researchers may not have answered the real questions that the program needs in moving forward.
Really important point. And the last question, please.
Lottie Rennick, Malaria No More UK. Next year is a huge year for malaria funding. We both have the Global Fund replenishment and the Gavi replenishment. Recent modelling by the Malaria Atlas Project said even if we just stay the same with Global Fund funding for malaria, there will still be an additional 280,000 deaths over the next 3 years. What can we do as a community to support those replenishments to make sure they're as successful as possible?
Great question. I wish we had time to put it to the whole panel, but maybe I just see if anybody specifically wants to pick up on that. Adrian, you breathing or? You blinked.
Clearly a mistake. Yeah, look, the answer in one sense is simple and the other near damned impossible. We need more money, right? We can't do this on the resources available. and we're fooling ourselves and everybody else if we pretend we can, incrementally improve things and keep going. There's a different route, and we need to find people who want to be able to tell their grandkids they raised money to control and then get rid of malaria, which happily their grandkids will then not know what they're talking about, because the damn thing will be gone.
That's a very positive note to end on, and a shout out, and really goes back to Fatima's hope that she'll be retiring, telling people there used to be this disease called malaria, but you won't know much about it from then. So we need to wrap up at the moment. So first, I'd just really like you to join me in thanking our fantastic panel. I think what we've learned today is there is a common cause to integrate different tools, and this isn't just about the tool, it's about getting them on the ground, getting them implemented, engaging with the community, engaging with researchers, and looking at this really holistically, which I think, sometimes we haven't done as well from our own little silos as that we could do to make this. I think the other thing that is very clear as well is that as we do start to win, and we'll win, and eventually it will be those who are most remote, the poorest, be the pregnant women, it will be the children in remote villages, and we need to make sure that we're really keeping our eye closely on equity, particularly in this time of the world where that slips behind. We need to think about this, how we can come together and really make sure that we reach that last person and make Fatimata's dream come true, that she's out of work, that nice early retirement for that. So just to finish up, I'd like to ask George to come back to the stage and maybe give us some concluding remarks. Thanks.
Listen, I took copious notes and wanted to see how the puzzle came together at the end, and I think it was a spectacular set of presentations that really did flesh out a lot of the key questions. They've said it very nicely in the recap, but I just want to remind people about a couple quick things I took away from those. Innovation is hard. Innovation means you fail. Innovation means you need to be forgiven for failing. You need to get up and keep going and pushing the envelope. And I think that's true for every one of the development efforts here. And it's not just about the tools themselves, but how we implement the tools. I actually had a board member once who say, why in R&D do we accept 10% success rate for early discovery, but in access programs you're supposed to deliver perfect access every time, right? The innovation, the integration that we have to have programs supported to do, they should be allowed to fail too, as long as they're trying better ways to make integration happen. And so I think that's a plea for saying business as usual nowhere is acceptable. Programs need to be supported to go ahead and try things that are not business as usual. But I do like what Ashley was bringing up about the integration. I mean, we have great programs like EPI. If we can attach more trains to the caboose or cabooses to the train to pull things along in an integrated way, that's great as well. We have to be, in the access team that I work on, we definitely try and challenge ourselves. Don't think in silos of delivery. It's not practical. But if we can be creative about riding on a few horses that are making delivery happen, that will help countries as well. And then lastly, just to say, over and over we heard one size doesn't fit all, right? Subnational tailoring has been a hot topic through the malaria ecosphere. But basically, subnational tailoring means asking the hard questions about what works here versus there, and what the right combinations are. And I think that's healthy today, that we're saying, of course we expect subnational tailoring to be the way that countries are going to do this. We're not casting blankets over whole countries like Ghana. Ghana will figure out what needs to be done where. So look, I leave on a note of optimism, but I will say that we're not going to leave this room thinking that the envelopes are there for what we need to do. Money matters. The money isn't there. And I think every organization like ours and anyone who's working in this space needs to revisit how we make the case even stronger, because it's going to be a couple of hard years ahead, frankly, at least in this country, to hold the gains about how important this work is. So that's a commitment from, I think, all of us here. We do need to keep up the messaging, and the messaging needs to be integrated, because people need to be excited that this really is a battle that can be won. So I think all of you again. And just a quick shout out, the TDR and MMV teams who worked to bring together an incredibly dynamic committee. I just want to thank Mackie, John, Gary, Lizzie, Danielle, and enjoy the rest of the conference.